Hello and welcome to this evening's Internal Medicine webinar. My name is Lydia Morgan and I'm Commercial Manager here at Virtual Veterinary Specialists. At VVS, we're on a mission to increase the collaboration between first opinion vets and specialists. Our goal is to help you to approach every case with confidence. We empower vets to work together in real time alongside our specialists, allowing you to deliver referral level care to your patients in your own practice. See our specialist as an extension of your own clinical team. We've expanded our virtual support with our VVS Internal Medicine Mentorship Programme, led by Professor Rob Foale, who's delivering the webinar this evening. This Internal Medicine Mentorship Programme provides one-to-one tailored support and personal guidance. Working together with Rob, you can take a fresh look at your case approach and choose your own unique goals based on your clinical aspirations. We are very excited to be collaborating with the Pet Blood Bank tonight on this webinar. I, like many of you attending, can name multiple patients who survived thanks to receiving Pet Blood Bank products. They really are life-saving. Tonight, my esteemed colleague Rob will be discussing the new product from Pet Blood Bank, Platelet Concentrate. As well as enlightening us on just what Platelet Concentrate is, he'll also be talking us through situations where it would be appropriate to reach for this product, and also those times when not to. It is my great pleasure to introduce Rob to you tonight. Rob became a recognised specialist in small animal internal medicine in 2005. He joined Dick White Referral in 2003, where he set up and ran the internal medicine and medical oncology services until 2016. He became a partner and clinical director at Dick White's for 5 years before leaving in 2021. He's been involved in teaching at the University of Nottingham since 2008 and has been a professor of small animal medicine at Nottingham since 2020. We are so lucky to have Rob on the VVS team, bringing his wealth of experience and knowledge, as well as his care and compassion. If you have any questions as we go through the webinar, please add them to the chat box. We'll be finishing up the presentation with a question and answer session at the end. So with that, I will hand over to Rob for tonight's talk.
Lovely. Lydia, thank you very much indeed. Good evening, everyone. Thank you for taking time to join me this evening. I hope you find what we're going to talk about informative, helpful, and hopefully just a little bit interesting as well. You don't want to right. So helps if I can work my computer. So a real pleasure. And I'd like to thank Pet Blood Bank for helping us this evening, and also for just being there. I'm sure, like me, all of you have, as Lydia said, hundreds and hundreds, thousands of patients across the UK that are alive as a direct result of Pet Blood Bank. And I got really excited at London Vet Show when I went to see them, say hello, and they said, oh, we've got a new product, which is what we're going to talk about this evening. So what I'd like to do is run through what is platelet concentrate. But before we do that, I thought we ought to talk about platelets, because to understand what platelet concentrate is and how we need to use it and when we possibly shouldn't use it, we do need to understand what platelets are, what they do, and also just have a little look into the future of where I think platelet medicine may be heading, certainly in human medicine and in the oncology field, where we may be going in veterinary medicine at some point down the line as well. So this is my little plan for the next 45 minutes. I'm going to review what are platelets, what do they do, how do they do it, then why might we have platelet problems in dogs and cats. I will talk about dogs and cats, but then focus obviously predominantly on dog when it comes to platelet concentrate, because it is canine blood that we have the platelet concentrate product derived from. And then we'll look at what is the difference between a thrombocytopenia and a thrombocytopathia, and run through how we should use the concentrate and when we should use it. And I hope then we have some conclusions, and as Lydia said, a Q&A at the end. So we all take hemostasis for granted, and I think, thank goodness we have it. But it's certainly something that medically has been recognized for quite a long time. And I'm not trying to claim to be some great Greek scholar. And if any of you do know me or know my wife, who happens to be Greek Cypriot, she will certainly attest to the fact I'm definitely not a good Greek linguist. But the word hemostasis is derived from the Greek. Hema is Greek for blood, which is, we use heme. And stasis can be loosely translated into Greek from the Greek of standing still. And it's referenced in the Battle of Troy, in Homer's Iliad, which is now probably historical evidence that existed, that did occur. So it's been around, we've obviously recognized its importance for a long time. But the interest in hemostasis started becoming sort of much more present in the 18th century when surgeons started to surgery as we know it started to become take off. And this chap here on the bottom bottom right hand side here, Jean-Louis Petit, was a French surgeon, and there was a lot of need for surgery developing from both as we started to develop industrial, not in the Industrial Revolution, but certainly sort of more accidents, but also war and battle injuries. And there was a group of surgeons, particularly in Europe, who would consider amputation and craniotomies as treatments. But obviously you've got a poor patient who is not anesthetized, has no pain relief at all. So they got very good at amputation. And Jean-Louis Petit was very happy to claim that he could amputate a whole lower limb within 10 seconds. They were actually doing some reading for this talk. There were a few people who said they could do all the amputation bar saw through the bone within 8 to 10 seconds, which just doesn't bear thinking about. But they obviously faced the problem of how on earth do you stop the bleeding? So what Jean-Louis Petit was famous for was to open the first tourniquet, screw tourniquet, which is actually very similar to battlefield tourniquets now, and also an abdominal pressure device to stop, to trigger hemostasis when they did the initial sharp dissections. But then also wrote reviews of how there must be something there to then stop the blood from coming out. So there must be something that changes in the tissue, which we now know is obviously related to both primary and secondary coagulation. And then the thrombin, the various parts of the coagulation cascade, started to be described in the early and mid 19th century, with thrombin being discovered and described by Buchanan, working up in Glasgow, then fibrinogen towards the end of the century by Hammerstein, and then the idea that Buchanan discovered that we needed calcium to be present for the whole clotting cascade to occur. And linked to this, a little later in the early 20th century, von Willebrand disease was described by Eric von Willebrand, but actually the factor itself wasn't identified for another 30 years. But that's obviously relevant to platelets because platelets interact with von Willebrand's factor. Now, platelets themselves, there's a little bit of debate in the medical literature as to who first described them. There's a German physician by the name of Max Schultz, who claims to have found the first, but actually the first proper description of platelets was by Sir William Osler, who is this so the picture of this chap here. Now, William Osler is very, very key in the history of human medicine. Interestingly, family history, he actually was going to follow his father into the priesthood, and went to Trinity College in Ontario and was persuaded to change tack and go to medical school, which probably was to his parents' consternation, but was probably a stroke of genius by the people who recommended him, because he became a professor of medicine at the age of 26. And a true pioneer in our field. If any of you on the call are in the middle or considering a residency program, William Osler was the first person in the world to plan, design, and run residency programs to spread teaching. And he also passionately believed in the importance of doctors having a good relationship with their patients. So he was the first person to teach medical students actually on a ward, which up until then was just considered an anathema. But he was also an outstanding clinician, and he was recognized that there were probably 3 constituents to blood. At the time, the only thing we thought was that blood was made up of red cells and white cells. And at the time, it was thought that white cells were actually the cells responsible for triggering coagulation. But William Osler was the first person to realize that to publish that there was a 3rd constituent. But what he didn't do is he didn't work out what they actually did. And this was left to, an Italian gentleman, Giulio Bizzozero, who was working in Turin. And 6 years after Osler described them, he actually worked out what platelets were, and he published. The issue was quite controversial to say that platelets were the cells responsible for coagulation, but he managed to show that the platelets could adhere to a surface. And that was the key thing he found, that they would adhere to a surface. And then once a platelet or some platelets are bound, more platelets would join. So he first was personally recognized that platelets could adhere to a surface, and then that triggered more platelet aggregation. He then also described there being fibers, which we would now call fibrin, that were then subsequently deposited on top of those platelets, and that seemed to make the platelet aggregate stronger. And he was the first person to name them as well. So, but it was a fairly controversial because, as I say, at the time, white cells were thought to be responsible for coagulation. And actually, Bezos went on and published quite significantly on the role of bone marrow in hemopoiesis. So very key to the work. What is a little sad, though, is when you think all these amazing people doing this work 130, 40 years ago, he died 3 months before the first ever Nobel Prize in Medicine was handed out. So with some fairly impressive work, though. In terms of coagulation, though, the sort of first time anyone thought about there possibly being a coagulation cascade, as we would currently know it, was by this German physician, Paul Moravich. The picture of him here is on the right. And although what he described was we would now think as incomplete, and it took another nearly 60 years before we actually worked out exactly what the blood coagulation cascade is, he did realize that there were factors, at least 4 stages in the development of a clot as we would now know it. So what's horribly sad and ironic, though, now that we know the role of platelets in atherosclerosis, was that Paul Moravich actually died of a heart attack. So horrible streak of irony within that. Now, when we look at the individual factors, weren't found until after the Second World War, and then the full cascade was actually described in 1964. So when you think we actually understood that platelets were present for the last 130, 40 years, the actual knowledge of coagulation is a relatively recent event. So what are platelets? Well, like teachers, I'm going to say suck eggs, but platelets actually have many more roles than just in coagulation. They are, firstly, they're anuclear, and they arise from these big cells, there's an example of which is down in the bottom right-hand corner here, these large cells in the bone marrow called megakaryocytes. And what megakaryocytes do is they produce little buds, and the platelets bud off, as is shown in this diagram on the top right here. And so the membrane forms a little bud, and it just disappears off. And megakaryocytes are factories. They're enormous cells. Just put in context, this cell here, this is a normal red cell. We're surrounding this megakaryocyte surrounded by some white cells as well. So they really are enormous, and that's relevant. Just thinking about if you've got patients with myelofibrosis, or particularly a leukemia, where the bone marrow is starting to be packed out with more cells than there should be there, megakaryocytes can literally be physically squashed. And one of the reasons you can get thrombocytopenia in leukemic patients is because megakaryocytes are unable to bud. What I find quite interesting is we've always thought that the only site of formation, sort of significant site of formation of platelets, was in the bone marrow. There's a paper out in Nature 5 years ago showing that actually they can be formed in the lung as well. And we know the spleen and lymph nodes and liver can have extramedullary hematopoiesis if needed. Normally hypoxia will trigger that, but this is the only paper, and the first paper I'm aware of, that said that platelets can potentially be formed outside of the bone marrow properly. They're not big, between 1 and 4 microns, although obviously there's a breed difference here with Cavalier King Charles, which we'll come and talk about in a minute. And they're normally a discoid shape. But the key thing about platelets is they can change their shape when they become activated. And they'll change their shape to fit the deficit that they're having to cover more accurately. We'll come on to how they do that in a second. Now, think about lifespan of cells in the circulation. Obviously, we all know that so an average cat red cell lasts about 60, 70 days, an average dog red cell about 80 to 90 days, compared to a neutrophil, which lasts around 12 hours. And platelets sit in the middle. So platelets live around about a week, depending on what their usage is, obviously. And they tend to change their size as they get older as well. I say older within that week. So a young platelet will be larger than an older platelet. And the platelets are removed from the circulation by the spleen. So that's how we through sequestered in the spleen and removed like that. Now, and just to put them in size and context, this is a blood smear from a normal healthy dog. So these are normal red cells. You can see in the middle here with the obviously biconcave disc and the central pallor. This is a platelet. That is a platelet. And this is a platelet here. So they're around about a quarter to a third the size of a normal red cell, okay, in the dog. Obviously, fetal red cells are slightly smaller, and platelets can be, but they look very, very similar in the cat. Example of Cavalier King Charles, I'll show you in a second. Now, platelets fundamental role, what we're talking about this evening, is obviously in hemostasis, and actually is a really helpful sort of physical parameter with which platelets circulate. Due to the way blood flows through vessels and the shear force on the vessel walls and actually the viscous nature of blood, platelets tend to get pushed towards the edge of the blood vessels. The red cells, the larger cell will go straight down the middle, which obviously actually is pretty helpful, because we want those platelets to be in very close proximity to the blood vessel walls, so that if there is damage or a break to the endothelial surface, the platelets can adhere and start the healing, stop the bleeding and start the healing process. So that is a physical feature that we do actually see. I've mentioned plate activation. Well, what do I mean? Well, if we look at an electron micrograph of platelet, you start to get into a little more detail, and they are pretty fascinating cells. And the first thing you see is that this platelet here obviously has got a varying shape. They have mitochondria, so they're metabolically reactive. They need to make ATP. And they also contain microtubules, and these microtubules are essential to help them actually change their shape. Brings in a question of, we'll talk a little bit about immune-mediated thrombocytopenia towards the end, but immune-mediated thrombocytopenia, there's a lot of people would believe that vincristine is an appropriate treatment, and it certainly, vincristine does cause the megakaryocytes, the bone marrow, to bud more and create therefore more platelets. But vincristine has its cytotoxic effect by stopping microtubule movement, so you can't have mitosis. And there is some evidence to show that vincristine actually affects microtubules in platelets as well. So whether platelets in patients with ITP, can they actually change shape as much? And the answer is not sure, probably not. But that's why the platelets have microtubules, that enable them to change shape. The third feature of platelets is they have this so-called canicular system. Now, these are literally channels. These are sort of canals through the platelet, which enabled. And why do they have that? That's a pretty unique thing within some cells. Well, the major feature of platelets is they contain granules. And there's actually 3 types of granules, only 2 shown on this diagram. But we've got what we call dense granules, alpha granules, and there's also some lysosomes. And the aim of the canicular system is that the dense granules have, and alpha granules, their contents, we need to get them out of those into the surrounding environment when the platelet needs to be activated. And so this canicular system enables all these granules to not have to always fuse the outer membrane. They can fuse the canicular system and then release their contents out into the local environment. So what's in the granules? Well, the first ones are the dense granules. They're the ones that look dark on that electron micrograph. And there's only about sort of half a dozen or so in each platelets, both cats and dogs and people. And what's in these dense granules is firstly calcium. Now, we know that calcium is not only needed as a cofactor in the some of the coagulation, secondary coagulation cascade. Calcium is vital for platelet activation and vital for platelet adherence. So platelets carry their own activation sort of system. It also has ATP and ADP to provide obviously energy source. It contains serotonin, and serotonin is important, and adrenaline, because they are both vasoconstrictory agents. So if you release the contents of dense granules, they will actually cause vasoconstriction of that blood vessel, albeit temporarily, and that then reduces the flow and gives more time for the platelets to bind and actually form the clot, whilst also potentially reducing the amount of blood that's lost through the deficit in the vessel wall. By far and away, though, the more numerous granules, these things are alpha granules, and there's a large number there. Now, these contain larger glycoproteins, and the glycoproteins are used as receptors and adhesion proteins because platelets have to stick to the tissue that they are trying to heal. And in particular, there's one called P-selectin. And P-selectin looks like a sort of long wiggly wire, really. But what P-selectin can do is it's able to reach out and actually help bind to the endothelium, bind to other platelets. So as well as having direct receptor interactions, the platelets can themselves send out, I used to use the word of fiber because it makes you think like it's fibrin, but they have direct sort of wires, attachment wires, if you like, and P-selectin is one of those. Other glycoproteins in there are adhesion proteins and also some growth factors, because platelets are involved in triggering tissue healing. And so growth factors to allow the endothelium and subendothelial tissues to start to heal. Platelets can help to stimulate that. However, to get proper healing, you also need to get some hydrolase. So there's these little lysosomal granules, and they produce hydrolases, which certainly help to trigger healing, promote growth repair, but they can also act as cytokines to the surrounding tissues, which also helps to drive the inflammatory process. So platelets come as a one-stop shop, really. They can be first the site of breakdown. So I suppose take a rugby analogy for Six Nations, they're the flankers. They're the first to break down, but then they can do everything. So like most back rows, they can run with the ball, they can get there to the breakdown, do everything we need them to do. But the key thing here is that so what are they going to do? They're facilitating hemostasis, stimulating wound healing, and they also help to initiate, but then partly to control the inflammatory response, because we need inflammatory response in the area of damage. So to put this diagrammatically, here we've got a diagrammatic version of a blood vessel with the endothelial cells on the side here, and there's been a breach, a deficit within that endothelial surface. And so as a result of that being there, the platelets have recognized that. We'll come on to how that happens in a second, and they have bound together. But when you look at a platelet clot, there's actually two components to it. The core, which is the platelets were there first, they are incredibly tightly bound together, very well adhered together, and very well adhered to the underlying tissue. But then there's a sort of a shell, a surface layer of platelets over the top, and they are not as densely packed, they're not as well bound together. But they then also have some of the fibrin that's lying at the top, and you can see the fibrin in both areas here. And these are platelets, nice discoid, spherical platelets, and they change shape as they start to roll along the endothelium. And actually, you can see here they change shape completely. It's about these tendrils with the P-selectin and other molecules that helps them stick together. So how do they do this? Now, this is a sort of slide that we all used to look at in sort of probably second year physiology, think, oh my goodness, and I don't want to bore you, but fundamentally, platelets do have large numbers of glycoprotein receptors. And there's a couple of key families, really. The first one is this 2B3A receptor here, which you'll see on several areas. And what that does is this is a receptor that allows platelets to stick to other platelets. So this actually will cause platelets to adhere together. And it also can help to recruit more platelets. And it also is involved in adhering to the collagen. So what triggers all this to happen? Well, actually, it is the exposure to collagen underneath that endothelial layer in the blood vessel. As soon as because the natural ligand for these receptors is collagen. So as the platelets are going along the edge of the vessel wall, if they come across collagen, they will automatically stick to it. And also with von Willebrand's factor, because obviously platelets are intimately involved with binding to von Willebrand's factor, which in itself can then stick to underlying collagen. So platelets can stick to von Willebrand's and then collagen, or directly to collagen itself. And that's mediated by these receptors. And that's why their position as they're traveling through the blood vessels is actually really crucial. If they were stuck in the middle of the blood vessel, which obviously some are, but the majority are rolling along the edges, and therefore will instantly come across the deficit and they will find it. So if we were to look at what a platelet looks like in normal circulation, these pictures on the left here, these are scanning electron micrographs. These are normal platelets that are, this one here is not activated. Maybe got a little bit of activation starting here. And this is a very simple electron micrograph before that we've got some of the 2-3 little dense granules here, a large number of alpha granules, and you can possibly see some of the little caniculae here. But this is a platelet that's been activated. So activation, it's come across collagen or von Willebrand's factor, and the binding of the glycoprotein 2P3A receptor triggers an intracellular signaling cascade, which starts to get the granules to be released, release their contents into the circulation. That then triggers the change of the platelets, gets other platelets to join and stick, and it becomes a sort of a brewing process. And if you look here, this is what the platelet changes its shape. Again, you can see it's much more flattened, and therefore it's much more appropriate to stick, and it can actually become cover a larger surface area than it could if it was just a sphere. So if we were to look at platelet activation as a summary, the key issue, or key trigger, is the damage to the blood vessel, and that exposes the subendothelial collagen. Then the von Willebrands can bind to the collagen, and the platelets can bind to the von Willebrands and or the collagen through these receptors. And that then triggers the intracellular cascade within the platelet that makes them change their shape, release their granules, and that triggers a promotion and aggregation of other platelets to do exactly the same. Now, along with that, platelets then also, I've said they release the content of the granules, they can also then start to, it catalyzes the conversion of arachidonic acid into some of the prostaglandins. So in particular, PGE2 and thromboxane. Now, why are these important? Well, they're important because they sort of seem to have contradictory roles. Thromboxane is a vasoconstrictor agent, and prostaglandin is E2 is a vasodilatory agent. But thromboxane is also has a positive feedback on making platelets express more adhesion factors. And thromboxane is inhibited at with very low doses of aspirin, the formation of thromboxane. And this is one of the reasons why certainly people who are going back, there's more modern agents now, if we go back 20 years, why were people who are at risk of vascular disease, cardiovascular disease, were recommended to take a low dose daily aspirin, is because what aspirin did, it blocked the production predominantly of thromboxane, which stopped the vasoconstriction in the coronary arteries, and it also reduced the degree at which platelets stick together and made them less sticky. So it is important. And then this then triggers the activation of the platelets, also causes thrombin release. And what does thrombin do? Thrombin converts fibrinogen to fibrin, and then that's the beginning, obviously. And we've got the secondary coagulation cascades. There's so intrinsic extrinsic cascades are obviously involved in this as well. And they are triggered by platelet activation to a large degree, and some of the cytokines that are released. And that then binds over the top of the platelet plug and glues it in place. Okay. However, and what we also have is tissue plasminogen, because platelets and their clots and blood clots, as soon as they're formed, actually the body starts to break them down and fibrinolysis occurs, because we don't want clots there forever. So although the clotting is brilliant, actually there's an inbuilt mechanism to break that clot down over time so the vesicle can go back to normal once it has been fully healed. So I just put this electromicrograph in because I really love it. So just put it in sapien size. Here's a lovely biconcave red cell. This is a lymphocyte, and here is an activated platelet. Okay, so although they are definitely different, but you can see by their shape and structure how useful they are at filling holes and stopping bleeding. So that is the function we know about. Platelets are crucial cells, incredibly active, that normally circulate fairly quiescently, but can be switched on and activated extremely quickly. And they form the basis of primary hemostasis in our bodies. But that's not what the only thing they do. And platelets are becoming, focuses of research in lots of different areas. And the first thing we know is that you may have heard of things called toll-like receptors. And toll-like receptors are present in the innate immune system and on all white cells. And what toll-like receptors do is that they can recognize conserved epitopes on the outside of pathogens. So that bacteria in particular have some conserved molecules on their surface that are common to many different types of bacteria. And they will bind, toll receptors can recognize them, bind them, and then initiate an immune response. But we now know that platelets, they have at least 9 types of toll receptors. The number of toll receptors probably seems to go up and up and up. I was looking at this talk when I last looked about a couple of years ago, it was 11. I think there's now 13 different types of toll receptors have been described. And we know that platelets express at least 9. So it does appear to be that platelets are able to recognize pathogens as well and trigger some form of immune response. And so it's definitely relevant within our innate immune system. The other really intriguing thing is that we know that platelets can release sort of microparticles, and particularly things like messenger RNA, in response to their local environment. So it appears to be that maybe through their canicular system, they can actually sense their local environment, and particularly if it needs to blood vessel tone. So we can change vessel tone, vessel integrity. And one area that this is really key in is in metastatic cell migration. One of the big area of research at the moment appears to be that migrating neoplastic cells that are trying to metastasize seem to be able to hijack platelets and then use the platelets to gain access through underneath the epithelium or the vessel endothelium, sorry, and in order to set up in their new tissue. So there's a lot of research going on of can we load platelets or block platelet binding and actually therefore stop metastatic disease. Won't be able to stop it necessarily, but it's certainly an area of research, I think, watch this space that is coming our way pretty soon, I hope. So we all think of platelets involved with hemostasis and thrombosis, but it's now crystal clear they have a role in host defense. It's crystal clear they have a role in tumor biology, both in tumor growth. They might be able to have an anti-neoplastic effect as well. And they're involved in inflammation. And already alluded to Paul Morovich at the beginning, and we know that platelets are absolutely key cells in the formation of atherosclerotic plaques in humans. And there's a lot of evidence to show that in patients with glomerulonephritis, that activated platelets in little microthrombi actually worsen glomerulonephritis significantly. So one of the things I'll do if I ever do have a patient with confirmed glomerulonephritis, clopidogrel is one of the treatments that it will be in the sort of combination I'm going to use. And lastly, we know that platelets are involved with normal vascular tone. So already alluded to serotonin 5-HT is a vasoconstrictor agent. Well, it's now known that platelets can reabsorb serotonin when they're resting. So it can actually cause vasodilatation and they can allow vasoconstriction when they release it. So they are very active cells and they're not just involved in blood clotting, albeit that's probably what all of us on the call are interested in this evening. So why should we worry about them? Well, what we're going to talk about this evening is when there's not enough of them or they don't work. And so thrombocytopenia is obviously the term that describes when we have a deficiency in the number of platelets in a patient. Thrombocytopathia is where we may have enough, but the platelets don't work to some degree or at all. So let's get into this. So what is a normal platelet count? Well, normal platelet count in our patients, and there's lots of different reference ranges, but in ballpark figures, 200 to 500 times 10 to the 9 per liter, or I can't do this, 20,000 to 50,000 per microliter if you work in American units, would be considered to be completely normal. Okay. Exception to that is greyhounds. Greyhounds are a breed that generally have lower platelet counts, but normally around 100 or so. And the second one would be Cavalier King Charles. Cavalier King Charles, about 50% of Cavaliers in an autosomal inheritance manner have what they call a macro thrombocytosis, where they have much larger platelets than normal, so therefore they don't have as many. So Cavalier King Charles, a platelet count of 60, I would say is completely normal. Okay. So now, one thing though, when it comes to platelet counts, is that analyzers struggle with platelets because they're the smallest cell in the circulation. So, and even if you go to a large reference lab using an ADVI or a Symantec, they will normally do a blood smear to double check the platelet count. So I would urge you, if you're not in the habit of doing that, to do so. And certainly if you've still got a QBC machine, they are really struggle to count platelets. So it's really, if you've got a microscope that has a times 100 lens, so the oil immersion lens, it's really quite easy. Go to the middle, make a little blood smear, go into the middle of the smear where the cells seem to be quite close but not overcrowded, and see if you can see some platelets. And the way to know if you could just count the number in your high power field, take 5 high power fields, get an average, multiply that number by 17, that will give you the number of platelets times 10 to the 9 per liter. If you can't see many, go to the feathered edge. And if you can see big clumps of platelets, which is often, they're sticky cells, they'll stick together if they can, that normally means you've got enough. You can't say what the count is, but if you can see platelet clumping, it probably means that you have enough. Now, interestingly though, as with so many things in physiology, there seems to be a big functional reserve, because it's a patient with a platelet count of over 50 will almost never bleed. But a patient with a platelet count of less than 30 could bleed anywhere at any time. Okay, so there's my sort of reference guides. If I've got a platelet count of less than 30, I'm not going to do a final aspirate of the liver, for example, even though the capsule is probably going to be tight. But a platelet count of over 50, yes, that's abnormal. I'm not going to be cavalier about it, but it's probably safe to do some sampling, for example, and the chance of that patient bleeding is very small. So why would we have low platelet counts? What can cause low platelet counts? Well, and you could apply this principle to leukocytes and potentially to red cells as well. If you've got a cell line in the body that is lower than it should be, then there's fundamentally three main group reasons. They can either be used up more, so consumption, or being sequestered in the spleen. We could have reduced production of those cells, or they're being destroyed. So let's get into that a bit more easier. So why would a platelet count be used up more? Well, the first thing is hemorrhage. If you are hemorrhaging, particularly chronically, then actually you're using platelets all the time. And so it is possible for the platelet count to drop into a dangerous level as a result, or certainly subnormal, and if sometimes a dangerous level because of that. And I'll introduce you a patient of mine in a minute who taught me that DIC, I think we're all taught death is coming, and it probably should be called imminently, is what we were taught at vet school. But I've come to understand that DIC actually can be chronic, and you can have DIC in a low-grade grumbling fashion for months and months and months. And the classic trigger for that is Angulostronchulus. So in the UK, that can lead to low-grade grumbling chronic DIC. And that will lead to gradual depletion of all the coagulation factors and your platelet counts as well. So hemorrhage, DIC, an unusual condition, hypersplenism. It's basically an overactive spleen where it's removing cellular constituents of the blood more rapidly than you would normally expect. So not something we see very commonly. You tend to get splenic enlargement and cytopenias, and your worry is it's going to have a neoplastic focus in there. Solution is normally to think about splenectomy, and those patients normally go on to do quite well. Obviously, it depends what your platelet count is, or before we have platelet concentrate, how we're going to manage these patients. So second thing would be reduced production. And this obviously generally is going to be a bone marrow problem. So it could be you've got myelophysis, so a leukemic involvement. It could be a myelofibrosis, which is probably an immune-mediated disease. But I think the things we've got to think about as well is viral and retroviral infection. So in dogs with distemper, hepatitis, parvovirus. Cats, you'd put FALV, FIV onto that list as well, potentially FIP as well. And I think a probably growing concern in the UK now, diseases that 20 years ago I didn't even talk about. But certainly now with the understanding, we definitely have tick-borne diseases, particularly in the southeast, in the southwest, Ehrlichia, Babesia, Leishmania. So these diseases can all damage the bone marrow and all lead to reduction in platelet numbers. And lastly, reduced production is systemic illness. So particularly significant neoplasia, anything that makes you suppresses the bone marrow, generally doesn't make them clinically give you a clinically low platelet count, but it's certainly something that could be there. Lastly, increased or abnormal destruction. Well, the disease we think about with this is immune-mediated thrombocytopenia. So classic presentation, Cocker Spaniel, American Cocker Spaniel, Springer Spaniel, 3 to 5 years of age, that just comes in pale and with ecchymosis or petechiation, and a platelet count that's normally less than 10. And I think the key thing with thrombocytopenia, immune-mediated thrombocytopenia, is it can be primary, as in those patients you often see, but it can also be secondary to another pathology. So you will see sometimes immune-mediated thrombocytopenia secondary to neoplasia, secondary to other infections, and very occasionally secondary to medication. Okay, so those are the things that would cause platelet counts to go down. By far and away, IMTP is probably the one that we would see clinically most commonly, but all these others need to be considered and ruled out potentially, or certainly thought about if you have a patient with a worryingly low platelet count. Now, I mentioned Cavaliers earlier on, and this photograph on the left here is the one you saw earlier. This is a normal non-Cavalier dog breed. I think this is a Labrador, actually, with normal platelets. And here we have Cavalier with almost exactly the same size red cells, but this is a Cavalier platelet that's probably 2 to 3 times the size of a red cell, whereas a normal platelet is about a third of the size of a red cell at the same. So that's where we are. Fran, thank you. There's a question come in here. Can greyhounds have average counts of 100? Does it apply to other sighthounds? And the answer is we think probably yes. Greyhounds do seem to be, greyhounds are slightly odd with their hematology, that they have lower than normal neutrophil counts, lower than normal platelet counts, and obviously they're a breed prone to hyperfibrinolysis. But certainly some of the other sight hounds, yes, it has been reported, but greyhound's the one that is most commonly recognized in. And this is a dog who, this brings back memories. This photo is 20 odd years old now. This is a dog called Buster, who I saw in the 3rd year of my residency. And Buster was referred to me because you probably can't see very good, but just above the bandage here on his right front leg, he's got a scar. And that was a scar that had been present for 2 years, and it just kept bleeding. And he was referred for investicoagulopathy. And when he first presented, I thought, oh, he doesn't look like he's got coagulopathy. We clipped him and took some blood, and this would look like huge hematoma formation and bruising. And to cut a long story short, he had chronic DIC, and we diagnosed with Angela strongylis. First patient I ever saw with angio. And he'd been unwell. He'd been doing this for 2 years. His platelet count, I think from memory, was about 23. So yes, I was slightly worried. But just as a flag really that DIC sometimes can be something that will hang around for much longer than you and I might otherwise have been taught. Now, I said that as well as having low platelet counts, sometimes platelets don't work. And these are now into the realms of slightly weird and wonderful, but there are recognized diseases where the platelets, you might have the right number, but they don't work well. And this can be either congenital or an acquired problem. So in the congenital list, there are a list here, but they're very much sort of breed sort of specific. So we've got in Otterhounds and Pyrenees, that receptor I said at the beginning, the 2B3A, that's really crucial to get the cells, the platelets to stick. That can be absent or reduced in this breed, so you don't get proper adhesion at all. You can also have signal transduction deficiency. So although you've got the receptor there, the activation of it doesn't lead to further changes. And this is something that's been reported in the Japanese Spitz and the Basset hounds, and we can actually test for these gene abnormalities in these breeds as well. So not common, but things to think about if you've got one of these, Otterhounds and Pyrenees aren't common in the UK, but Bassets certainly, and we see a reasonable number of Spitz. So these things, you've got any of those breeds with a coagulopathy, this is something you might be thinking of a particularly younger dog. And same with dogs, you can have a storage pool deficiency where we have the right number of dense granules, but they don't work properly. And this has been reported in American cockers. Thinking of cats, Shediac-Higashi syndrome is a very unusual disease, recognized more in people, where you have an inability to phagocytose sort of pathogens. And these patients often will be neutropenic, have poor platelet function, and also have be albinos. Interestingly, in cats, we don't tend to get albino because it's seen in smoke Persians, but it is something that's been seen, and these patients, when they're young, will end up having coagulopathies. Border collies with cycling neutropenia can also have abnormal platelet function, and German shepherds will also things. And of course, good old boxer can't stay out of the pathology list. But we don't quite know why boxers do this. A small number of young boxers will certainly have abnormal aggregation of their platelets. So there's certain breeds here that we can see that may have thrombocytopenia. Probably more commonly, though, is when we have an acquired platelet dysfunction. And there's quite a few medications you and I will use that will affect the way platelets work. The first one, obviously, is non-steroidals. And most of the non-steroidals we've got are COX-2 selective. And we really talk about COX-1 here. So, but there are some reports that platelet aggregation could be affected after carprofen, but doesn't seem to be clinically a problem for our patients. But certainly, some antibiotics can affect platelet function. There's some anesthetic agents that will. And it goes without saying that cytotoxics, obviously, will damp down cellular proliferation. And one can certainly cause thrombocytopenia because the half-life of platelets is so short. So if you stop platelet production a couple of days, then you will see a reduction in the circulating levels. Slightly more concerning drugs you may not have thought of are the calcium channel blockers that we use in cardiorespiratory medication, where there has been proof, certainly in vitro, that these drugs can affect platelet aggregation and platelet adherence. So whether that's truly clinically relevant, but if you have a patient that seems to have an acquired thrombocytopenia and is on maybe diltiazem or verapamil, probably diltiazem, then it may be that it's the drug that's causing the problem. Again, a growing thing, though, the biggest thing for me now would be infection. And I think FALV, FIV but particularly FALV in cats, but Ehrlichia markedly affects platelet aggregation and could cause quite significant hemorrhage if you have a patient who's positive with Ehrlichia. And then kidney disease will affect platelet function, liver disease will affect platelet function. So there's an awful lot of things that will affect platelet function and could potentially lead to hemorrhage. So how do you know? How do you and I know as clinicians that we've got a patient who may have abnormal platelet function or abnormal platelet numbers? Well, certainly if it's a congenital thrombocytopenia, then hemorrhage at deciduous teeth shedding, could also be von Willebrand's disease, I suppose, gingival bleeding, mild epistaxis, shifting lameness, because you're having a bit of joint hemorrhage intermittently based on exercise. These are all signs that could be anything with a coagulation cascade, but a thrombocytopenia or thrombocytopenia needs to run a differential diagnosis. And your main differentials for this obviously would be thrombocytopenia, von Willebrand's disease. If it's a greyhound, excessive fibrinolysis, but the greyhounds don't come up in the thrombocytopenia list. And if it wasn't one of these breeds, it might be the dog has, or cat has actually got a secondary coagulation deficit as well. So just very briefly, I just mentioned von Willebrand's disease because it's not linked to platelet concentrate in any way, but obviously von Willebrand factor is vital for platelet adherence to the underlying subepithelium and also platelet-platelet interaction. And this is, though, well recognized in certain breeds, 3 different levels of severity, from mild, probably hardly affected, through to severely affected, so you might see in Scotties. And the key thing with this is that von Willebrand's disease is one of those diseases that will cause abnormal platelet function test results. So these are clinical pictures from patients, all who've actually been thrombocytopenic. So we've got and the classic thing with thrombocytopenia or thrombocytopenia is you tend to get small diffuse hemorrhage. So this is petechiation rather than overt hemorrhage. Buster, the dog I showed from residency, not only did he have a platelet count of 23, he also had markedly prolonged OSPT and APTT, so had primary and secondary coagulation deficits, which is probably why he developed that huge hematoma over his right shoulder. What we have here, though, is little tiny petechiation, normally on the gingiva, but you can find it on the pinna, maybe around the external genitalia. This is on the ventral surface of the abdomen, maybe starting to go towards an ecchymosis there. But here we've got on this little Westie, we'll meet this Westie in a second. These are other little petechiation. And this is actually, this is a patient that caused me a lot of heartache. We did eventually get it right. This is called Pickle. Never good. Pickle was owned, her dad was a lawyer and her mum was a human nurse. So I had someone who really knew what they're about and someone who could do something to me if I didn't get it right. But I got to know very well. Pickle was a patient. She had immune-mediated thrombocytopenia and actually had presenting signs where she was, she had pallor, she had some petechiation, but she, quite unusually, actually had melena. And she was having, so this is melena on the newspaper here, staining her perineum, which is an unusual presentation for thrombocytopenia or thrombocytopenia, but it's something I have seen, and we did eventually get Pickle right. So if you've got a patient with any of these, what are we going to do? How are we going to know what's going on? Well, first thing, obviously, we're going to do a hematology. Is there, and if you've got a regenerative anemia, there are only 2 things that can cause that. You've got hemorrhage or hemolysis. Hemolysis doesn't have to be immune mediated, but that's a subject for a different seminar. So, and then we're going to do a platelet analysis. I want to know what is the platelet count and confirm that with a blood smear. And then look at the clinical signs. If I've got large cavitatory bleeding, large ecchymosis and bruising and hematomas, it's probably a secondary coagulation cascade abnormality. If I've got small petechiation, mild hemorrhage, or not clinically relevant hemorrhage, but it's there, then it's more likely to be a platelet issue. So we can assess, obviously, coagulation using OSPT or PT and APTT or whole blood clotting time. But if they're all normal and we want to investigate primary hemostasis, then the first thing we need to do is double check that platelet count and then have a look and see, is that on one of those breeds that might have a thrombocytopenia? We could then do a von Willebrand's assay. We could do buccal-mucosal bleeding time, which is probably what most of us go to in practice. What I haven't put on this list here is obviously we can also do platelet function testing using thromboelastography. The problem with TEG testing is it needs to be done on a fresh sample, ideally taken within about 30 to 45 minutes of it coming out of the patient. And it's only generally either 1 or 2 referral centers and one of the university clinics who have access to a TEG machine. So the way you and I in practice are probably going to work out if there's a thrombocytopenia is to do a buccal mucosal bleeding time. Word of warning, never do a buccal mucosal bleeding time in a dog that's thrombocytopenic, because you know it won't stop bleeding if there's no platelets. So only do buccal mucosal bleeding time if you suspect that there is a thrombocytopenia, so you know you've got normal platelet count, but you think you've got a primary coagulation abnormality. How do you do buccal mucosal? Well, this is very simple. These little Simplate devices, which you can get from any of your wholesalers. And the best way I found to do it is if you lift the lip up of the dog and just gently put it, not tightly, but put a little bandage around that, just hold it up there so you don't have to touch it. And this little Simplate device is it's like a pinprick device where it's got a tiny little blade. Press the button on the side, it shoots out, shoots back in again, makes a tiny little 2 to 3 millimeter shallow incision. And then you just let the blood start to flow. And use anything to block the blood away. Don't touch the actual cut itself, just because you don't want to disrupt the clot. Just touch any sort of dripping around the edge. And what you should find is that in a normal dog, this will clot within and stop bleeding within about 1.5 to 4 minutes, and about 1 minute to 2.5 minutes in a cat. Okay, if it's markedly prolonged and the platelet count is normal and the secondary coagulation test is normal, do you know you've got a thrombocytopenia? So what can you do about it? So if we've got platelet abnormalities, well, we now are extremely lucky to have access to Platelet Concentrate. And I put out, I genuinely mean it, Platelet Concentrate is a very precious bag of brilliant canine platelets. And it's, how do we make it? Well, what the Pet Blood Bank do is they take a fresh unit of whole blood, so 450 to 500 mils, and they'll spin that blood in a soft spin to remove most of the red cells, and then siphon off the plasma that contains the platelets, so-called platelet-rich plasma. You'll then do a further centrifugation of that, and you get a little platelet plug in the bottom. And they'll take off most of the plasma, and then we can obviously have that as plasma, but they'll resuspend, keep about 60 to 70 mils, and then resuspend that platelet plug in that, and this is what we get. So this is how we make our platelet-rich plasma. The key thing to remember about it, though, is that we've spun it from whole blood, and in human medicine, let alone in veterinary medicine, you can never be 100% certain that all the red cells have been taken out from that product. So any patient that you and I are going to give platelet concentrate to, you must type them for DEA 1.1, and you must use a compatible donor. So a platelet concentrate that's been obtained from a 1.1 positive or 1 negative dog, whichever is appropriate for your patient. Once we've got this, when we're going to decide we're going to give the platelet concentrate, you basically, it's the same as doing a blood transfusion, just quicker. So what we're going to do is we're going to give 1 unit of platelet concentrate per 10 kilos, okay, and it goes through a standard blood giving set, so filtration, sort of a device in there. And we do the same as we do with a blood transfusion. We're going to get it slowly to start with, so around about 0.5 ml per kilo per hour. So nice and slow for the first 30 minutes, constant monitoring of that time frame, temperature, respiratory, mental status. How is the patient? Do we have any worries at all? And if there's no sign of a reaction, so a marked spike in temperature, increase in respirate, heart rate, or deterioration in mental status, we can then increase the infusion rate. And because we're normally going to be giving this, and the advice I'm going to come to me is, one of the major uses of this is in patients who you know are bleeding, you want those platelets in as quickly as you can. So the Pet Blood Bank would normally recommend it's given over 2 hours, but they've proven to be safe if you give it carefully with good monitoring in an hour in patients where there is active hemorrhage. Some practical aspects of the product, and then we'll come on to when we would use it, is it's got platelets have a very short half-life and shelf life. And actually, the fact we Pet Blood Bank of managed to get it to 3 days is excellent. And there's work, I understand, going on from Pet Blood Bank to see if we can prove that it can be extended safely to 5 days in the near future, which would be brilliant. As all our blood products, it's precious. It's not the cheapest thing. So those are the costs you have there. The cost is the same, be it 1.1 positive or negative. And obviously, if you need it same day, then there is a delivery courier charge on top. But I know Pet Blood Bank are looking to work with some larger referral and probably university centres, so to maybe have some more local supply to reduce the costs when needed. Now, the question is also, what do you do if you've got a dog, let's say with a congenital thrombocytopenia, and it's maybe had platelet concentrate, and then a couple of years later you think it needs some more? And you can't do a major cross-match in platelets, but there is a technique to do minor cross-matching. So at the moment, PET Blood Bank are saying that we don't need to cross-match these patients if they've had a previous transfusion. But what is absolutely essential is to match the donor to the blood type, 1.1 positive or negative. But this is something we're keeping in constant review, and it may be this advice changes over time. But at the moment, that is the advice that the PET Blood Bank are giving. So when should we use it? Talked about what platelets do, how we can have low platelets, and what we know is that platelet concentrate is good at increasing platelet numbers in patients that have got thrombocytopenia, or it's brilliant at giving a dog with thrombocytopenia platelets that will actually function. So the two main indications for when we should use platelet concentrate is in patients who you know have got a thrombocytopenia or a thrombocytopenia and are actively hemorrhaging. Okay, and platelet concentrate will hopefully stop that quicker than certainly whole blood, because the number of platelets you get in a unit of whole blood are actually lower than it would be if you give it platelet concentrate. Now, the big things here, if you've got CNS or pulmonary hemorrhage, particularly, so I want to talk about its use in immune-mediated thrombocytopenia in a second. That's actually not one of its major indications. But if you've got a patient that is actively bleeding, and we had this problem with Pickle, that little Westie I showed you, she did develop pulmonary hemorrhage. And this would be, I wish I had platelet concentrate for her then, because my life would have been an awful lot easier at that time. So active hemorrhage in a patient who's got thrombocytopenia, thrombocytopenia, platelet concentrate is your drug. It is certainly something we could reach for, and it should be very effective. The second main use for platelet concentrate is a patient who you've got a diagnosis for thrombocytopenia or thrombocytopenia, and you know you're going to have to plan an invasive procedure, so a surgical procedure or biopsy procedure of some sort. So this doesn't stop us. You still got to do all your normal good hemostatic preparation, but this is something you could use electively and prophylactically to try to reduce the risk of hemorrhage as a result of the procedure that you're going to do. And those are the two main uses that PET Blood Bank are envisaging and would like to platelet concentrate to be used in. And interestingly, if you look at the human side, in human medicine, these are exactly the two times they would use platelet concentrate. Platelet concentrate is a precious resource in human medicine, just like it will be for us. And these are the only two major reasons that they would think about giving it. The third what they do is in patients with, because obviously human medicine push their chemo patients harder than we do. Patients who have got severe thrombocytopenia as a result of chemo and are at risk of hemorrhage, then they would you certainly think about giving platelet concentrate in that scenario. So when shouldn't we use it? Well, the one thing that I think I just want, maybe I'm going to disappoint some of you on the call now. Platelet concentrate probably should not be used in a patient with immune-mediated thrombocytopenia if they're not bleeding. And the reason for this is severalfold. Firstly, patients with IMTP actually very rarely bleed, even though sometimes they've got platelet counts of, we can't find any. 2 or 3 is not unheard of in IMTP. And yet, despite that, they seem to very rarely bleed if we treat them properly. So if they're not bleeding, given the platelet concentrate it will increase the platelet count, but it's probably not going to last very long, because the second reason is that platelets in patients with IMTP have an extremely short half-life because they're being destroyed. So the focus of our treatment in immune-mediated thrombocytopenia has to be really significant immunosuppression, identify the disease and immunosuppress them. And I would not use platelet concentrate just to increase the platelets, because we're probably going to lose those platelets very quickly. But I would think about using a platelet concentrate in a patient with IMTP if they've got active hemorrhage. I'm just waiting for my immunosuppression to work. Okay. So although we see a lot of IMTP, what we ought to focus on these patients is gentle handling, good immunosuppression, plus minus vincristine, or whatever else we want to give, and only use platelet concentrate in those patients if they've got CNS or pulmonary or significant other hemorrhage, and we just need a bit of time to see if we can get those patients to be stable. And that's pretty much what I wanted to say. So in conclusions, I think platelets, vital cells, they're way more active and have many more roles than I think a lot of us imagine that they actually have. And coupled with that, though, a lot of things will make the platelets counts go down, or have a platelets that aren't functioning very well at all. So it's really crucial that if you have a patient has got what you think is a primary hemostatic abnormality, to get a diagnosis of, is there a primary platelet dysfunction, or is there something else in that patient, be it medication or pathology or infection, that is causing the platelets to not work very well. Platelet Concentrate is an excellent, brilliant, fantastic product for us to have that will, without doubt, save many lives over the coming years. But we do need to use it in the right place and at the right time. And I say it's whether you've got active hemorrhage in patients with a known thrombocytopathy or cytopenia, or as a prophylactic use where we're trying to prevent there being a problem in the first place. And that is me. Thank you very much, indeed, for your time. I'd like to publicly say thanks to Lydia for all your support getting this together. Lydia, you've been great, and for running things through for me. And also to Helen Rooney. I don't know if Helen's on the call, but Helen is the induction and training manager at Pet Blood Bank, super qualified vet nurse and a general all-round good egg. And he's been brilliant and supplied the pictures. So I need to thank that. And thank you very much for giving your time. And I'm very happy to take your questions if there are any.
Thank you, Rob. That was absolutely brilliant. Particularly enjoyed the rugby analogies when describing platelets. That was a good highlight, but it was fantastic. Thank you so much. And we do have a few questions coming in. So if you're happy, we're just going to go through some of these questions. First is, how long do platelets last in circulation? And I presume that's the platelet concentrate.
So it depends. It's a really good question. It depends on what the pathology is underlying it. If there's immune-mediated thrombocytopenia, then that platelet half-life could be very short, and they may last only a few hours, which is one of the major reasons why we're not advocating its use in immune-mediated thrombocytopenia unless it's active hemorrhage. The duration of life of platelets in the circulation from platelet concentrate without there being immune-mediated damage is currently an issue of debate. There is a school of thought in human medicine that they may have a shorter half-life, so they may last for 2 to 3 days. I've also seen evidence to show that they probably have anything up to 5 days. So I think it's probably safe to say we're not totally sure, Lydia. I think 3 days you'd expect should be fine. We might be lucky with 5, but it's unlikely to be any more than that.
And with that in mind, for elective procedures in patients that you know have thrombocytopenia or apathia, what period in advance of the elective procedure would you administer it, or would you do it during?
No, I think for this, I would be giving it on the morning of the procedure. So you've got maximum level of platelets in the system, circulating happily. There's been no adverse sort of reaction to the platelet transfusion. So if I was doing a biopsy, or I don't do them, I would ask a surgeon to do my biopsies for me, then I would be giving it in the morning and have that procedure planned lunchtime, early afternoon, keep the patient in for 24 hours to make sure there's no complications. If you then don't, if there's a problem 2 to 3 days later, then there's still either a problem with fibrinolysis or the secondary coagulation cascade, but those platelets should work in that time frame. The key thing there is, obviously, depending on what you're doing, they might need a second transfusion. Okay, so that's really where you just need to be careful and make sure the typing is absolutely perfect.
Thank you. And Helen has said that she's attending, and thank you.
Helen, thank you very much for your help.
And Kerry has asked, what about administration? Free flow, or can you use pumps for platelet concentrate?
Helen, please correct me if I'm wrong, but I would be happy to use a pump. You can use pumps with whole cells, and actually the larger the cell is, it's more likely to be damaged with a pump. So platelets being the smallest ones, the giving set is the key to make sure you have a proper blood giving set for those. Free flow, if you don't lucky enough to have a pump, just make sure your drip counter's working well and you're monitoring the volume. But I would be happy to use a good quality pump in this.
Helen has come back and agrees. So thank you, Helen. We appreciate that. So we've also got a question. I'm interested in using them to support liver/spleen/lymph node FNA for patients with suspected neoplasia. The issue is knowing if the underlying pathology is immune mediated or not. Would that be appropriate use for platelet concentrate?
So it depends what the platelet number actually is. If FNAs, so FNA of a peripheral lymph node, I will happily do that in a thrombocytopenia patient because I can stick my finger over the hole for as long as needed if it bleeds. But you are right to be careful in patients with in liver and splenic FNAs. Horrible story, but we did have a patient referred to us about his colleague actually 4 or 5 years ago. And I won't say who, but the referring vet told us the platelet count was normal and the money was tight. So we trusted them and did the FNA, which then 3 hours later, you start to see the liver pumping a little bit of blood, and we found the platelet count was 15. So if the platelet count is if platelet count is above 50, I will happily FNA liver and spleen. And actually, if the liver and spleen have a normal capsule, so there's not a sort of fibrotic process or a neoplastic process, then actually the capsule should retain hemorrhage within that solid organ, and then they shouldn't bleed anyway because the pressure would control it. If you've got a platelet count of less than 50 and you're concerned it's a neoplastic process, then actually I could see, yes, this would be a situation where platelet concentrate would enable you to undertake those FNAs more safely and get an accurate answer to that patient in order to make the right treatment decisions.
Fantastic, thank you. We've had a question, do you use vincristine regularly in IMTP?
Oh, there's the 6 minute. Oh, that's a good one. Do you know what? It's another seminar on its own, how to treat IMTP. Thank you for the question. Yes, I do, but I'm going to caveat that. So my approach to IMTP would be to use prednisolone, and I actually use azathioprine from the beginning. So 2 mg per kg once a day. You do not use to twice a day. And I don't exceed 50 milligrams total dose. So if I've got a 80 kilo dog, I'll only give it 50 milligrams. And I'll do that dose for 2 weeks, then slowly tap it down. Azathioprine 2 mg per kg every other day. You can't use azathioprine in cats, and you can't split the tablets. So and it needs to be used in care with anyone who's pregnant or young people in the house. I do use vincristine, and I use it at 0.1 mg per meter squared, one-off IV. I know some colleagues will repeat that dose 7 days later. Now, the pros and cons of vincristine. It is definitively known to cause budding of megakaryocytes. So if you give vincristine to these patients, you definitely increase the platelet number. It might be transitory, but you do increase platelet number. The debate is, do those platelets work? So because I've talked about the microtubule in them, and there is some papers in human medicine showing that if you give giving vincristine to a patient that needs it, that you stop the binding to the collagen, but you don't necessarily stop the binding to the von Willebrand's factor. So platelets probably can still bind with the vincristine on board, but not as well. Secondary, it is true that platelets probably can't change shape as much, so that they can release their granules, but they can't change shape. They don't make as effective a plug. But if you and I look at a patient that's a platelet count of 3, I'll do anything pretty much to get that platelet count into a level that enables us to go home and relax. Why do I think vincristine works, though? There is another theory to why vincristine works. This one I'm interested in. We know that vincristine actually can be taken up by platelets and can be stored in some of the lysosomal granules, and it gets access through those caniculae. And how are platelets destroyed in IMTP? Antibody binding and macrophage engulfment is how they're normally destroyed. So there is a theory called the toxic platelet theory, which is where a macrophage comes along, excuse the vernacular here, identifies the platelet, engulfs it and gobbles it up, but it gets a mouthful of vincristine and that kills the macrophage. So it may well be that you can actually target killing the cells that are causing the cellular destruction of the platelets by loading the plates with vincristine. And I'm really intrigued with that. And I suspect that's actually why vincristine causes benefit in patient ITP rather than being the megakaryocytic budding. But that's only gospel according to me, Lydia. I don't know. So I do use it, but at 0.1 mg per meter squared.
This might need to be our next webinar, IMTP, with you, Rob. I know it's a really interesting topic. And if anyone does have an IMTP case that you'd like to discuss with Rob, Rob also does advice calls as well about your cases, so can talk you through the ins and outs of your specific cases. And then this is probably a slightly similar question, I suppose, or out of interest, could giving platelet concentrate to patients with uncontrolled IMTP potentially worsen the situation, stimulating an immune response against foreign platelets?
Oh God, that's a good question. I don't know if it would worsen the situation in that you're sort of feeding the fire. You've got immune-mediated destruction already, and if they are obviously donor platelets, then I don't think you'd make it worse in terms of making the immune destruction worse. It's more that you're wasting the platelets, yeah. And that's the problem. Will you cause increased cytokine milieu? Of course you will, absolutely. Whether that's detrimental, I don't know if anyone's proven that. So it's a really good question. I don't think the evidence is there to say we know whether it make it worse. My hunch is it wouldn't. The worry is that we may then not have access. You won't. Yeah, the pressure resource is gone. But if the dog is bleeding, I wouldn't hesitate, because if we, sometimes patients, I mean, CNS hemorrhage, you've got to stop it as soon as you can and recover. Pulmonary hemorrhage, if you can stop it even for 6 hours, you know, just and then get Vincristine on board, Pred or Dex if it's obviously you need some IV, nasothioprin, cyclosporin. I use, and I know this is not licensed, so just to make this clear, off cascade, I'm a huge fan of mycophenolate in these patients as well, particularly cats. I know IMTP is not common in cats, but I've had probably 3 or 4 cats where the only thing that's worked is mycophenolate. I've done Pred, cyclosporin, bit of Vincristine, and then go, oh, what do I do now? And give them the mycophenolate, and the platelet count just rocketed, and it stayed really well. And cats tolerate mycophenolate very, very well. So it's off, it's bottom of cascade, but I have used that successfully. Although the literature says mycophenolate with variable success, my experience of it's brilliant.
We do have a feline question. What about cats? Is there a realistic chance for a feline product in the future, or a place for xenotransfusion?
Oh, Anna, I can't answer the question whether there's a product in the future. Helen might better answer that. Feline blood is incredibly precious because it's so much harder to get. So Anna, we might come back to you on that. Xenotransfusion, look, that's a really interesting question because it is possible to cats and cat blood transfusions, you know. Cats do have auto antibodies against the opposite blood group. So if you've got a type A cat, it has antibodies against type B, although they're weak hemagglutinins. If you've got a type B cat, it has very strong hemagglutinins against type A. So if you give a type B cat type A blood, you are highly likely to kill it. Type A cat given type B blood, you will cause an immune-mediated reaction and a hemolysis that probably won't kill it, but might. So, you know, something to be careful of. But you can give cats dog blood. And you can give dogs human blood. You can give dogs pretty much anything, actually. So it is something that you could consider, but I don't know. I'm very wary of giving cats anything other than cat blood, just because they're so much more reactive than dogs. But if you're in an emergency, you could give a dog human blood, actually, and it's probably going to be okay.
Wow.
Helen's come out, sadly not very likely soon. So Anna, the answer is yes. Pet Blood Bank work on it, and they'll see if they can get it out as soon as we can. So
tricky product to make, I think, that one.
Yeah.
Interesting one. Will there be any adverse reactions if the patient has already used tranexamic acid before the transfusion?
That's a really good question. Isik, I don't know. Is the answer. Let's think. Okay, let's go back to the first point. So what tranexamic acid is doing is blocking the fibrinolysis. Okay, so in your classic one would be the greyhound. That is, you do a procedure. I had advice on a greyhound with a dental last week. That brilliant piece of dental work, the look of it, and then hemorrhaging everywhere within a couple of hours. And what's happened there is the fibrin's being broken down, so the platelet clot just can't form. I can't really see why there'd be an adverse reaction, because if you're giving platelets to a patient that doesn't have any, then you've more likely to get, you've then got the scaffolding on which the fibrin can form. If you've got tranexamic acid on board, it means the fibrin will be maintained. So I can't see there being a problem for that. I guess the question would be, is if you've got a patient on tranexamic acid and we're having to give it platelet concentrate, I just would worry is the diagnosis. I don't mean this rudely, is sick if you've got a case. I'm happy to chat about at some point. But I'd worry why we have to give something to increase platelets and do fibrinolysis, because that would be an unusual combination of things to have to do. So I can't imagine an adverse reaction. I will certainly look into it, and maybe we can come back to you if you've got the details. Find something in over the next couple of days.
I was going to say that might be something more in the human literature. They use a lot of tranexamic acid. So, and then finally, one more question: would you envisage using it in cases of, for example, traumatic hemoabdomen when performing permissive hypertensive resuscitation?
Hey, that's a good question tonight, Lydia. Terry, thank you.
I know, they're challenging me with my pronunciation and all kinds of challenging words for this time on a Thursday evening.
Terry, I suppose at this point to confess, I'm definitely not an ECC specialist. I'm a confirmed internal medic who's probably colleagues who work with me say I'm not very good at ECC. So let's think about it. If you've got traumatic hemoabdomen, in those patients, I would, yes, I suppose there would be a rationale to using it, but only if the platelet count is significantly low. So if your platelet count is above 50, and certainly a lot of these patients would be, because the platelets are there, and the spleen can release some more, and you have more than enough than you need. So if the platelet count was normal, I probably wouldn't. If the platelet count was dropping, I think this would absolutely be an opportunity to where you're using hypertensive resuscitation, and you need to get those platelets in to stop the hemorrhage. I think this would potentially be a role in that. Absolutely, yes.
Fantastic. Thank you. I think we have gone through all of our questions. Let me see if I can see any further. That's all the questions. So thank you everyone for your really interesting questions. I'm just going to pop in the chat box a link to our mentorship program. So if you are interested in working with Rob and talking through, your approach to internal medicine cases, as I'm sure you've all can appreciate from tonight, he is fantastic at his problem-orientated approach. And I love with all those questions how you're taking a step back and really looking at it very logically rather than rushing into the answer. I think that represents your approach to your cases very well, Rob. So thank you so much for a brilliant webinar. I really enjoyed it, learned a huge amount. We've got a few, I think there's just one final question. To your knowledge, do congenital collagen defects such as Ehlers-Danlos syndrome cause coagulation defects?
Hey,
And
George.
I will
That's right.
that be the last question, I'm afraid, everyone.
George, hey, how are you, mate? I hope all's well with you. I was only talking about you yesterday with John Grieve, so I hope all's well. Look, thanks for your question. Oh, that's a really good question. Now, Ehlers-Danlos, it depends on which degree of Ehlers-Danlos you have. Okay, and so there's. God, you're now stretching my knowledge. There are 4 different degrees of Ehlers-Danlos, and yes, there are some because the collagen defect in type 4. So people who don't see as much, but I've got a friend, a human nurse, who has this. This, I've got some big idea, Ellie, Lydia, sorry, is that you've got abnormal collagen, and the collagen fibers are there. But I think I'm right saying that in the type 4 Ehlers-Danlos, the GP23BA receptor can't bind as well to it. So those patients, have wound healing deficits, but they can also bleed when they have wound healing. And some of those patients will get chronic arthritis because they get intra-articular hemorrhage. So I'll come back to you if I'm wrong. I think mildly affected Ehlers-Danlos syndrome, it's unlikely. Severely affected ones, yes, they will have coagulation deficits, is my understanding.
Fantastic. Well, thank you so much, Rob. That was a really brilliant presentation. Thank you everyone for coming along. Our next webinar will be with Dr. Claire Nottenbelt talking on oncology, so keep an eye out for that. And yes, hopefully Rob will be joining us for that one as well, but watching rather than presenting in that circumstance. Well, thank you everyone so much. Have a lovely rest of your evening. If you have any questions for Rob, then please do email us at info@vvs.vet and we would be happy to pass those on to Rob. I've just put that again in the chat box. And thank you for your time, and we hope to work with you soon.
Thank you, everyone. Really have a great evening.
Take care. Bye.
Bye.